Good afternoon, good evening, good morning, depending where you are in the world. Welcome. Welcome to this Africa regional launch of the report of the 3D Commission. My name is Sandro Galea. I have the privilege of serving as Dean of the Boston University School of Public Health, but I'm here mostly in my capacity as chair of the 3D Commission. The 3D Commission, which was a partnership between Rockefeller Foundation and Boston University, focused on the intersection of data, social determinants, and decision-making. The vision behind the commission was to say, we are beginning to realize more and more how the conditions of where we live, work, and play, so-called social determinants, shape our health. But as we move forward, as we're trying to understand better how to act to improve those determinants, to improve health, we need better data to measure the social determinants. And how do we bring together then measuring the determinants, understanding them to make better decisions for health? The commission was conceived, and launched in early 2019. And the reason that's relevant is because we did the initial planning and thinking before any of us had ever heard of COVID. When the commission unfolded, it unfolded starting towards the end of 2019 and obviously throughout 2020, all against the backdrop of COVID. And I think that sharpened and focused the commission's thinking because, of course, if COVID has taught us anything, it is that the consequences, even of a pandemic, are really all about the world around us, all about our social and economic conditions, much more than about the virus itself. Before we get into our panel, which is really the main show today, I wanted to share a couple of slides just to summarize the findings of the commission. This is the cover of the report, which is available online, and I would encourage anybody to go on the website. You can simply Google 3D Commission or 3dcommission.health. This is the commissioners. We have 24 commissioners from all over the world, and a couple of whom are on the panel today. And I'm immensely grateful to the commissioners for the work that they have done. One of the things that the commission did is commission, so to speak, a global survey asking people what they thought were the key drivers of health. And what we found is that the majority of people thought that health is mostly driven by healthcare still. This, of course, is at odds with a modern understanding of health, where we realize that most of health is not driven by healthcare, but actually rather by the conditions in the world around us. And I think this speaks to some of the gulf that there is to bridge between what we understand about health and how the general public sees health, which of course influences how those in a positions to make decisions can make decisions about health. I think a modern conception of social determinants fundamentally takes into account of the full range of forces, from politics and governance to religious and cultural forces, conditions of neighborhoods, social positions, networks, assets, and our behaviors all throughout the life course, all growing with us from really the perinatal period all the way to adulthood. And understanding that sets the stage for us to have a full notion of the range of factors we want to intervene on, want to measure, and we want to make sure that our policies reflect as we make decisions that affect health. What tends to happen is a figure from the commission report today is the figure on the left, is stylized, which is, yes, there are the social determinants, which is the squares here, but there are many other competing priorities. And yes, there are data sources, traditional and new data sources. All of these sort of compete and jostle for positions to lead to decision-making. Perhaps a more idealized world, as represented by the schematic, is on the right, which is that decision-making for health is central to how we do and think, that we recognize that local, national, regional, global decisions fundamentally all should have health in mind, all should elevate health, bringing inputs from a range of data sources, new data, and as well as traditional data sources. Aiming to catalyze conversation on this exact topic, the commission articulated 6 principles and 4 recommendations, which I'll quickly summarize here. The principles, I'm not going to read all of them, but very quickly, start from saying that in order to have evidence-informed decision-making, we need to go beyond healthcare and incorporate data from the broader social determinants of health. And that all decisions made about investments need to be made with health as a consideration. Health equity needs to be at the heart of any health decisions. It's not simply about improving health overall, but trying to reduce health gaps. And we should use all available data resources, from qualitative data to narrative data, all the way to population-based data. The data that's collected should be collected in a way that's transparent and makes for more accountable governance, that we all recognize that we all see the data that's available, as well as communities see data are available, and that communities are involved in the gathering of data and are included in decisions that are made from these data. And we felt that these principles fundamentally should be an underpinning to a forward-looking data conversation that informs decision-making around social determinants going forward. And this led to 4 recommendations. And all the recommendations pertain to global, regional, local entities. The first recommendation is that these entities systematically collect in real time qualitative data that characterize the full range of social determinants and make that available to decision makers. That we have transparent systems that collect data about social determinants and explicitly use these data in decision making. That we should embed follow-up and monitoring. So that's not just about collecting data, being transparent about the collection, but also that then we can monitor and follow up and say, where did data used to generate decisions that generate health? And finally, that community engagement in acquisition and interpretation of data should be a core to how we think about data and making data available to these relevant communities. When one launches a commission like this, the intent really is to help seed conversation, to help seed ideas, and to catalyze action throughout the world in various sectors: academic sector, and decision-making sector, and the civil society sector. And one of the ways we're doing that is trying to reach out with the messages of the Commission. And these launches are a series of launches aiming to do that. We launched the main report coincident with the UN General Assembly 2 weeks ago. And now we're doing a series of 5 regional launches, this being one of them. The format of the launch is we have Dr. Jeff Sturcio, who was the managing director of Rabin Martin, also a commissioner and the core intellectual partner of the Commission, who will be leading a panel of local experts really around the ideas behind the Commission and looking forward to say, how do we take this work forward? With that, I'll turn it over to Jeff. Over to you.
Thank you, Sandro. It's really a pleasure to be here with everyone, and I'm looking forward to our discussion where we'll be exploring the various regional challenges that are being experienced in Africa that may hinder the potential for incorporating a data-driven approach to improving decision-making for health grounded in an understanding of the social determinants of health. We'll also look at potential opportunities for building a new foundation of public trust in decision-making grounded in political will, technical capacity, and community engagement. So I'm looking forward to hearing from our panelists, but first let me introduce them to you. Just briefly, we have David Pararanyatwa, who's been Minister of Health in Zimbabwe, and he's now the Vice President of the Society for AIDS in Africa. Dr. Magda Rabalo, who's High Commissioner for COVID-19 and a former Minister of Health in Guinea-Bissau. Sheila Tlu, who's co-chair of Nursing Now Global Campaign and the co-chair of the Global HIV Prevention Coalition. She's also a former Minister of Health in Botswana. And Jesse Uneke, who's the Director of the African Institute of Health Policy and Health Systems at Ebonyi State University in Nigeria, where he's also a professor of medical parasitology and health policy and systems. So it's really, as I said, a pleasure to welcome everybody. And let's get started. Let me go first to Dr. Pararanyatwa. As the former Minister of Health in Zimbabwe, what steps did you take to ensure that decision makers were investing in initiatives that incorporated or addressed the social determinants? And what challenges and opportunities do you see in integrating every sector into the decision-making process as it relates to decisions about population health?
Thank you very much. Jeff, can you hear me?
Yes.
Good. Well, let me first recognize and appreciate this particular 3D commission. We really are very excited here in the Africa region to have this sort of 3D report, which brings about a very critical conversation, which needs to be sustained. And I believe it should be broadened and, of course, followed up. And indeed, we need a feedback thereafter. And we think that the 3D principles really encompass, in short, what is required within the region. And you are aware that there is this principle of leaving no one behind. We hope that this will not be just rhetoric in terms of appearing or buttressing what is happening with the 3Ds. But let me go straight to some of the issues that you have raised. And I'll go and just talk about some of the challenges and perhaps the opportunities that we have in the Africa region. When I was Minister of Health, which was for quite a long time, in fact, I was Minister of Health for almost 12 years. And one of the biggest challenges that I had was the issue of prioritizing the health sector, the issue of just the hierarchy in government, in cabinet. Where does health stand? There's always a feeling that perhaps finance, maybe defense, are more senior ministers, so to speak, and health is relegated perhaps to the fifth or fourth position. That was a big challenge in terms of being listened to. And of course, following that, it was then the issue, the challenge of resource allocation thereafter. And if you have poor resource allocation because you have not articulated the health sector well, then you find the issues of human resources for health. That's what I faced. The number of nurses, the number of doctors who left the system and did not only go into the private sector, but actually out into the region and beyond the region. That was a big issue, the loss of well-skilled, well-trained human resource. And of course, you are aware that as a developing country, we've got a lot of clinics out there in the rural areas where perhaps there are no pharmacies. And one of the biggest challenges is to provide adequate medicines in those clinics. If you do not have a medicine in a clinic out there in the rural area, then clearly you are not satisfying, you are not looking after the most vulnerable of our people. And that was a big challenge. And again, if you look at the issue of ICT, a big challenge still. And we want to perhaps promote now telemedicine to be able to connect with the remotest of clinics. And if you have poor resources, your programs suffer. HIV suffers, TB suffers, malaria programs, they suffer. And finally, you find that your people will continue to complain that our health system is not doing well. So those are challenges that we faced. And of course, we need far more community involvement than hitherto. You want to know what their fears are, what their expectations are, how they can contribute. And a lot of them want to contribute. And there's no point building a clinic when they don't want that clinic in that area. So that was also a big challenge, which is usually solved by just consulting through appropriate bodies. You cannot just consult willy-nilly. There has to be structures. There has to be proper structures that are not necessarily regimented, but recognized, so that whatever comes out of those communities is something that you can use. Furthermore, it was a big issue to coordinate the non-health sector. It was very difficult to coordinate NGOs, for an example. You needed to be able to, because you remember there was this issue called the 3 1s principle, where you have one framework, one coordinating system, and one monitoring and evaluation system. And to get an NGO who is not in government to subscribe to that, you have to have a structure that can accommodate them. So it was a very big challenge to coordinate NGOs, to coordinate donors, and to coordinate the private sector, and to coordinate the faith-based organizations. And in Africa, faith-based organizations, especially the Pentecostals, are heavy. They are really everywhere. And you need to have them on your side, but they need to have that, to remove that disconnect and build linkages with them. Well, we could go on because if you look at COVID now, I don't know whether COVID has changed the people's outlook towards the health system. I think everybody now is really recognizing the importance of health because of COVID. And I found that people who used not to talk about health are now almost expert at talking about social distancing, about the symptoms of COVID. So that has had a negative effect in that it killed people, but at the same time, it highlighted the importance of the health sector. Jeff, I don't know how much time more I have, but I could lecture on and talk and discuss more, but clearly there are a lot of other things that we could talk about. So maybe I'll leave it here for now.
Okay, well, thank you, David. And I I think you've given us a good sketch of just how complex the task of a Minister of Health is. that was really helpful for a start. And since several others on the panel have had similar experiences, I'm sure we'll come back to those issues. Let me turn next to Magda Raballo, who's now the High Commissioner for COVID-19 in Guinea-Bissau. Magda, let me ask you, it's been said that COVID-19 has really illuminated all of the fault lines in health systems around the country, around the world. And one of those fault lines, and Sandro mentioned this, and the 3D Commission has looked at it, is the question of health equity. So I wonder if you could talk to us about, in leading the national response to the pandemic in Guinea-Bissau, how have you and your colleagues worked to ensure that health equity is one of the key principles of your response?
Thank you. Thank you so much, Jeff. And my predecessor, I would like to thank the Commission for the timely launching of this report. I think in a time of a pandemic where science is put on the fore and challenged many times in many dimensions of our planet, it is healthy to be discussing a report that focuses on the importance of data for decision making. Yes, it's true that COVID came to remind us how unequal our world is, both within countries and across countries. Particularly in Guinea-Bissau, our work in fighting COVID took us to, first of all, improve the data infrastructure. Our major challenge in Guinea-Bissau in the health sector is to have timely, complete, reliable, and useful data for decision making. This is a major challenge, and COVID came to illustrate how far behind we are lacking. So we are building data acquisition, analysis, and use infrastructure for COVID, but also for with ramifications in other sectors. Our focus is on communities that are deprived from water, sanitation, poor housing. COVID social and public health measures for prevention insists on social distancing, on washing hands, on making sure that if you use your face mask, you throw it in the bin, you wash your hands before and afterwards. And this is where social determinants of health comes in. Our schools are not fit for COVID times. We have overcrowded classes, we have overcrowded housing, we have people living on the fringes of what is needed for COVID-19. So our focus was to design a data collection instrument that will take you up to the neighborhood, not just district level. You go up to the neighborhood to identify where are the more at-risk people, where are they living, how are they living. When our brigade of volunteers visits transmission focus intense, they focus on people's housing and adjusting sensitization measures so that if you have an infected or two COVID infected people where you are living and you don't have space, there is no way you can distance, social distance or physical distance. You need to adjust your response to the realities of your country, of your neighborhood, of your health system. So really, our data capturing system had to be designed in ways where we can locate individuals, go to their house, and then Fortunately, we are not such a big, huge country. We have a 2 million population, and we are close by systems to reach people. But let me also comment on the difficulties the world is facing in terms of coming closer to a more equal world. I think we are living in times where populism has increasingly becoming a challenge, where health is not yet perceived as a major driver for sustainable development. I think Minister Parignatwa mentioned that. Difficulties and challenges in bringing the response from other sectors, for example, for COVID, Minister of Education understanding that if you want to fight COVID, you need to invest in the schools in order to help the health sector control infection. Ministry of Environment, Ministry of Public Works, the multi-sectoriality and the impact that has on health is something we need to continue working on. Governance issues, democracy issues are very important for us to use data for decision making and for us to impact on equity issues that are confronting the health sector. I will stop here, and a lot more can be said about this.
Thank you. And I particularly liked your emphasis on the multi-sectoral or intersectoral nature of responses to health crises. That, you know, it isn't that health really is a foundational issue for sustainable development. And as you said, there are aspects of education, environment, public works, and other ministries who really have to be brought into this response. And that certainly is part of the focus of the 3D Commission, is to look at those social determinants and how they have an impact on decision-making that will improve population health. So I'd like to turn next to Sheila Tlu, who, like you, has been a former Minister of Health in her country, Botswana. And Sheila, you were one of the commissioners, so you're familiar with the approach that the 3D Commission took. Could you tell us how you were able to integrate data sources and perspectives on the social determinants of health to influence decision-making on population health issues in Botswana?
Okay, thank you very much. And let me thank my colleagues for joining us. I mean, being a commissioner, it's really been great for them accepting to be part of this event today. So thank you very much, Magda, David, and Jesse. Let me, I'll caption that with a saying: when leadership is from the top, great things happen. I was a very lucky minister in that I came in when President Mogai was the president. And if there was one person who was already sold on to health, it was that one. I came in from a research experience, being an academic, but also a civil society activist who had done a lot of research on HIV and gender and human rights issues. So that in that portfolio, I was already a member of the National AIDS Council, a council that was chaired by President Mogai. I think you participated in that council, Jeff, or at least ACHAP. Now, this was as multi-sectoral as we can get it. All ministries. There was nothing like ministries related to health. Every ministry participated in that council. The various sectors, from the prison services to the uniformed forces, including our development partners, the donors, as well as the multinational researchers like the Botswana Harvard Partnership and ACHAP, of which you are still a member. So this was the forum where all relevant data was put in, and there was discussion on how then it can be used to drive policy, especially towards the AIDS response. So it was really great, because then even data from civil society was used. My own data on how we can be able to work with women in preventing mother-to-child transmission was very much used. So that when I then became a minister, it was really then to carry that forth, but also to ensure that at community level, civil society is well funded. And I must say that, okay, one of the challenges was really human resources for health, but it then became using all what we had, working with communities and everybody else to say where there are no doctors or limited numbers of doctors, and we have nurses and nurse practitioners, what is it that we can do? And how then do community healthcare workers fit in? So the great part was that we actually had resources at that time. My condition for becoming a minister was very comfortable as a professor. So when President Mogai said, look, with what you've done and your passion for HIV, can you come and help me in the AIDS response? I said to him, I'll come only if you give me 15% of the budget. I mean, I knew this was a honeymoon I could not miss. So, and I knew too that in 2001, the African Union leaders, our political leaders, had said they would devote 15% of the health budget to health, I mean, of the national budget to health. So to me, it was like that at least has got to be the minimum I'll accept. And he said to me, I'm actually giving you 20%, but I want a report every 6 months. So that right there was accountability to say, do and show what you can do. And indeed, we became as multi-sectoral as possible. And I must admit that we became a great practice for Africa in that within the 4 years, we had brought down mother-to-child transmission from 28% to 8%. So, and we really worked hard, and we put out policies that were later copied by WHO. For example, the provider initiated voluntary counseling and testing. We had no data to lean from. We had to produce our own data. And later I presented it at the AIDS conference in Toronto, and WHO was able to then say, we are going to have guidelines on voluntary counseling and testing, especially the provider initiated one. So basically, I mean, the ingredients are there, leadership at the top, but also resources for health. That's what we need. Yeah. Thank you very much. I think I'll stop there.
Thank you, Sheila. And I'm glad that you emphasized the multi-sectoral nature of the HIV response in Botswana, because, you know, I think that that was really a hallmark of Botswana's approach, that it was a whole of society approach to HIV/AIDS, which, as President Mogai had said, was an existential threat for the country. And as a result of the work that you were involved in, of course, Botswana became one of the first countries to meet the UNAIDS 90-90-90 targets. Really, there was a tremendous turnaround in the impact of HIV/AIDS on life expectancy in Botswana, for instance, which went back to levels that it had before the HIV pandemic. So that shows what, as you said, what can be done when you have leadership from the top, a multi-sectoral response, and the resources needed to really bring in all three of the 3Ds to improve population health. Well, let's turn next to Jesse Uneke, who is from Ebonyi State University. Before I ask a question to Professor Uneke, I just wanted to remind people that you can ask questions by using the Q&A button at the bottom of your screen. So we'll be turning to questions from the audience in just a few minutes. Jesse, let me ask you, I want to come back to this theme of intersectoral collaboration. And, you know, can you talk to us about how you've worked on incorporating data from the broader determinants of health from all sectors into the work you've been doing on evidence to policy in both the African Institute of Health Policy and Health Systems, but also the broader WHO related efforts that you've been involved in? You know, how have you been able to bring this kind of intersectoral collaboration together in addressing improvements in decision-making in health?
Yeah, thank you very much, Jeff. And I want to join my colleagues, co-panelists, to thank the 3D Commission for this very exciting meeting. I want to start by saying that data is very, very important in decision making. But the problem we are having in most low and middle income countries is that there is a huge divide between those who generate data and those who are in the position to make use of data. And that has created a problem in our evidence to policy making process. You cannot make effective policies without robust data, especially locally generated data. So what I've tried to do over the past 15 years is to see the strategies that we can use to bridge that divide between policy making and research. And that's one of the reasons we established the African Institute for Health Policy and Health Systems. And then the reason why we've been driving the evidence to policy process in the West African sub-region. There is a lot of research going on in the institutions of higher learning, but very few of this research is going into policy making. And the reason is that there is this mutual mistrust between researchers and policymakers. Excuse me. And so we try as much as possible to see how we can build some informal relationships between researchers and policymakers by bringing policymakers and researchers together to reason together, to discuss, and then to also see how research can be tailored to the needs of the policymakers. This is it's been quite challenging because this gap has remained, but we, over the years, we have done the best that we could to bring researchers and policymakers to start discussing how the challenges can be addressed amongst them. And this has helped a lot to make the research going on in the universities to now become acceptable to the policymakers. So that's one very important accomplishment that we've been able to do in our work in Nigeria. And I want to also say concerning the inter-sectoral collaboration, the COVID-19 has introduced a new dimension of collaboration in the entire social system. Now, the reason is that before the advent of COVID, most ministries, including the health ministries and the health sectors, have been working in isolation. There's this kind of silos that are built around each sector, and there is little or no intersectoral collaboration. But you see, the COVID-19 pandemic, it's not just a health problem. It has cut across all the social aspects of the life of mankind. Now, I remember, you can also bear witness to that when the pandemic set in, even schools were affected. Businesses were affected, the economy affected, every sector affected. So it was not just a health problem. People now saw it as one particular problem that will have to bring together everyone to work together to overcome it. And personally, it's one of the gains, I can say, permit me to use that, it's one of the gains of the COVID-19 pandemic, because people who couldn't work together before, sectors that could not collaborate before, had no choice but to come together and start working together. I remember in many instances, stakeholders in the health sector came together with stakeholders in the education sector to start thinking how to have safer schools. It never happened before the advent of COVID. And that has introduced a new normal in our way of doing things and collaborating with each other. And this is exactly what we need to be able to advance the health sector properly. And in terms of the intersectoral collaboration, still from the perspective of COVID-19, we see the education sector, the environment, the agriculture, housing, energy, even culture, and even from the political point of view, we have sectors coming together. And this, the collaboration that we saw by the sectors coming together helped us to be able to some extent, win the war against COVID-19. And I think from my own perspective, we should let this go on. We should build a framework where we can have this collaboration to continue, because we are not trying to be pessimistic, but the world may not have the pandemic as the last. We could still have many more other kind of catastrophic events coming up. So we need to build a robust intersectoral collaboration so that we could even share data. You cannot properly address the health sector challenges if you don't have information from the environment sector. You cannot also address the health issues if you don't have information from the housing sector. So we need all this information, and we need stakeholders to partner. So what we have been doing in Nigeria through our institute is to see how we could bring stakeholders together from different areas. It was quite challenging because people didn't have that experience of working together. But the COVID-19 has created a platform where people now come together and see that there is a common problem that everybody faces, and they now see how they can now take care of it. And then finally, we also saw from our work that it is not just enough to engage policymakers and the researchers, as well as the NGOs and others, but there is a very critical stakeholder that often we miss out, and those are the parliamentarians. The parliamentarians are very, very critical in the decision making because they make the laws of the land. Policies are made into laws through legislation, and the parliamentarians also need data. They need evidence for them to make laws that will help the society, that will help the population. And so what we've been trying to do also is to extend the engagement to the parliamentarians, and then to teach them how they can also work with researchers, how they can share information, how they can assess information, and how this information can be used in legislative process, such that the laws that are being made are also evidence informed. Thank you very much, Jeff. I will take some more questions.
Okay, well, thank you, Jesse. And that I was particularly interested in what you said about how COVID-19 was kind of a forcing event to ensure that there was a new level of collaboration among different sectors to address the pandemic. And I hope that you're right, that you'll be able to have a robust and resilient framework for continued intersectoral collaboration, because there will be other health crises in the future. The other point I wanted to come back to, and let me pose this question more broadly now to the rest of the panel. You talked about the divide between those who generate data and those who use data. And you also gave the example of how working with parliamentarians to provide data to them so that the decisions they make are evidence informed. Those are all important aspects. I wanted to just ask David and Magda and Sheila, who have had the experience of being in government and having to make decisions. You know, it's often said that public policy decisions are made under conditions of uncertainty, because you have to make a decision, but you can't wait for all the data to be in. So how did any of you can jump in here, how did you find the right information you needed to make informed decisions when you were in government and had that responsibility? Oh, David, you're on mute.
Okay, it's quite a broad question and a difficult one, because in the past, most ministries were more silo, and then once in a while there will be an interministerial togetherness. But of course, we all meet in cabinet and share. But in terms of statistics, they were very segmented in terms of siloing in ministries. So there's a strong need to have a separate body that can truly coordinate all this data, all these statistics, not just for the health sector, but for the benefit of all the other ministries. So you really, this 3D commission has got a lot of work to do, because just to collaborate that in a country, that data, and most countries have got a department that does statistics, but it's more of gathering the statistics, but not the applied part of it, not to use them. So I think, and then the ministries have to extract those statistics from the statistical office, the central statistical office. But there's no real collaboration that how it can effectively be used. So I'm saying 3D Commission is a real huge task to create such a body, or to help countries to create such a body. Maybe in our particular case, there's a strong need to lobby this up to the AU level, such that everybody knows what's happening. And also, I know that you launched this at United Nations. I'm sure eventually you go to United Nations General Assembly with 3D and articulate these positions. There's real big need. Whoever thought of this 3D, whether it was you or Professor or Sandro, it's really a brilliant thing. And we must see it through, because it has its own niche, and that niche must be satisfied. And all these questions will come into that, including what my colleague Jesse said. He's an expert on policy, he's an expert on strategy. So those are the things I think we may have to look at, Jeff.
Okay, thank you, David. Magda, did you have a comment?
Yes, I do. My contribution is to say this is where the intersection between hard data, soft data, triangulated, empirical guessing, experiences from neighboring countries, from the global village come into play for you to advance with decisions that may not be totally supported by data, that you may not have the full spectrum of what you need from the different sectors in order to push forward the policy that is very much needed. And trial error, learning from doing, is also going to be important. I think if we were going to wait until all the information is available, we would have never put in place some of the programs that are actually saving lives in our context. So I think, and also it is important to realize that the culture of believing in data is something that is, you built it as you go on. Not every government, not every country, not every program has the data it needs before it can function. Look at what is happening about mental health, non-communicable diseases. We have very broad statements on low and middle income being the more affected by non-communicable diseases. But when you look for data, it's really not there. So I think we need to build the boat as we sail, learn from other countries, learn from what's happening around, and adapt to our circumstances. And that's how I think we need to navigate it. Thank you.
You know, I think I particularly liked your point about learning by doing. I think that's an important element of how to get to public policies that really will have the best impact on population health. Sheila, did you want to comment?
Yeah, thank you very much. I think I agree with, and I really believe what my colleagues have said. But because of our utilization, we had a lot is not utilized. So that any data that we needed, for example, if I needed data on how we reach adolescents, it was really a question of going to where the source of the funding was. For example, PEPFAR was the one that was for abstinence and all that. I mean, I still remember I had to quarrel with them when they would not fund condoms, but would fund abstinence. And I said, I'm fine. I'm working with the Ministry of Education on that one. So it was really then a question of making sure that at the Ministry of Education, they generate data to see what teachers, what the preparation of teachers that is needed, and what about students? What do they need, pupils and all that? At what grade should we introduce what kind of education? So that we were able to do that. And we then said, let's look at models of what's happening in the rest of the world. As Magda said, we went to Brazil and they already had something that they were doing in terms of comprehensive sexuality education. So we put up the Talk Back program that has been very successful in terms of reducing teenage pregnancies and really ensuring that teenagers, especially young girls, are not that affected by HIV. But let me end by simply saying, in the ultimate, as Magda said, health is a political choice, and the use of data depends on what is viewed as politically correct at that time. As a professor, I had data on prisons, and I used that data as a professor with my students to smuggle in condoms into the prison, because I was told that sodomy is against the law. So we decided we'd smuggle condoms in that case, because we had evidence as prisoners came in uninfected, they came out infected. So rather than say we'll fight that law, it was like, that's beyond us, but we'll do what we can do. Learning by doing. So I figured that when I become a minister, I'll have the cabinet with that great memorandum to say, I'm going to now have condoms in prisons. And it was really something else. Almost more than half of the ministers did not want to hear that. It was like, you are going to cost us elections. That is not done. You don't forget that you are specially elected. You have no constituency. So, I looked at our president, who I had briefed, and he believed in that. But what could he say? He said to me, Minister, democracy in the ultimate works, so maybe you should just continue smuggling condoms. So I thought, to hell with democracy. This is one time when I really wanted dictatorship, because he could easily have said condoms in prison. That would not have. And we had data, but that we knew that wouldn't work. So, health indeed is a political choice in the ultimate. Thank you.
Sheila, that's a terrific example of just how health and politics intersect in decision making. So we have a question from the audience. Let me just pose this. The one question people had, and maybe Jesse, you might want to comment on this, is I'm wondering whether any of the panelists had experience with qualitative data to answer policy decisions when the quantitative data may not be available or may take too long to develop.
Yeah, can I answer this one? Can I start?
Sure, Sheila, go ahead. Go ahead.
Yes. Well, as a professor, I'm an ethnographer. I believe bringing up the lived experiences, especially of communities, so that most of the time I relied on that. For example, in clinics, when I came in, the emphasis was mother and child health, which was great. But then, with the lived experiences of women, I was able to say, no, we value women from the womb to the tomb. So we are going to have services for all women, especially those ones at menopause, because they had no idea what was happening. So that's when that kind of data was we were able to use that. So that the lived experiences of communities were very much taken into account, mainly because I came from that community aspect myself. Yeah, thank you.
Yeah, thanks, Sheila. And I think that's an important point, that there are opportunities by getting different data sources and by working with communities to ensure that policymaking really reflects the lived experience of the population. I think that's an important point. Jesse, did you want to come in on that question about data?
Yes, that's a very, very important question. And I want to respond from the perspective of both the policymaker. Qualitative data gives you deeper insight and much more very important aspects that you cannot get from quantitative data. And sometimes quantitative data takes so long because you need to do some analysis and all that. But qualitative data gives you opportunity to really understand the mindset of the people, their thinking, and then some other social aspects that you cannot easily capture in the use of quantitative data. So sometimes in policy making process, when we're looking at assembling evidence for policy making, qualitative data is very, very vital because you get to understand so many other things that the quantitative data cannot give you. And then we know in the policy making, when we talk about the types of research evidence, we also have evidence coming from experience. We have evidence coming from people's exposure to certain kind of conditions and situations and circumstances. We also have some kind of evidence that are not documented at all, but you can get it from the people due to their, they are living in a particular situation or condition for so long. And so you can get vital information just by interacting with them, asking them questions, interviewing them, that you cannot get from any other source. So sometimes when we are really talking about making policies that are evidence-based, we do not only use evidence that is coming from maybe like primary research, but we also have to do some qualitative investigation because you can get certain kind of information that no other source will provide that for you. And then the qualitative data is always very fast. You can get that very fast. You can synthesize that very fast. And with the technology advancement today, like Zoom, you can interview anybody almost from anywhere and in any place. And that will give you some information that under normal circumstances would have been very difficult to get. And we are talking about policy making, and in policy making, we want to make policies that are living policies, policies that are breathing, policies that are alive, policies that can really make the impact, policies that the effect of the policy. And you cannot do that. You can't get that kind of policy if you don't get to interact with the people and know what is in their minds, know their feelings, know their experiences, you know all this to build it into the policy-making process. So what we try to do in the policy arena is to try as much as possible to promote qualitative research as one of the most vital aspects of the evidence you need to make certain kinds of policy. So we promote that. And for a policymaker who needs information as fast as possible, because you don't have all the time, like the researcher who has the luxury of time, but the policymakers do not have all the time, and they need to take certain decisions as fast as possible. And like some of my colleagues who have been ministers of health, there are certain situations you face. You need to take decision, and you just have to work with the data that is available to you at that instance. So we try to promote qualitative research and the qualitative data because you can have access to that kind of very quick information which you need to be able to take some kind of decisions. So I don't know if it makes sense to whoever that asks the question, but that's one of the things we are trying to promote now in the policy-making process.
Yeah, no, thanks.
I was
can
just
give
going to
quick.
comment on that one.
Okay, David, go ahead.
A very quick one. The issue of qualitative and quantitative data is critical. But a practical example we're facing is the pandemic of substance abuse. Now, there isn't enough data, solid data, to perhaps look at size estimates of how much there is. But there's so much talk about how children, how youngsters, how adolescents are abusing drugs. Now, for the policymaker, he would say, okay, we have heard children are no more going to schools because of COVID. They are now abusing drugs. Can we make policy now before data comes? And I think this is a practical example of whether you want to go qualitative or quantitative as you make policy. I just thought I would throw that in.
Yeah, no, thanks. That's an important example. And Magda, I think you had a comment you wanted to make. You'll have the last word because we've run out of time. Go ahead.
Yes, I just wanted to share with you, in the context of COVID, we have established a risk communication and community engagement group. And what they do is work with women, religious leaders, traditional leaders, and they work by focus groups, small research, finding meetings, and they use the outcome of those conversations in the mosques, in churches, with the traditional leaders and traditional health workers to feed into the messaging and address the rumors and the barriers to adopt COVID preventive measures. So this is just to give you an example of how on a daily basis, on a weekly or monthly basis, we capture qualitative data from the people to use and shape the messages and then feed it back into how we organize our response to fight COVID. I thought I would share this experience as well. Thank you.
Thank you. I think a conclusion that comes from all of your comments is that decision makers need a diverse array of different data sources. And often the best way to get some of that data is through engagement with the communities who are who have the experience of living with different health conditions. We could go on for some time, but unfortunately we've run out of time. I want to just thank David Pararanyatwa, Magda Rabalo, Sheila Tlu, and Jesse Onyeke for a very lively conversation. And let me hand it back over to Sandro for some closing remarks.
Well, thank you, everybody. First of all, I want to echo Jeff's gratitude to David, Sheila, Magda, and Jesse. I learned from all your comments. I really appreciated the echoing of some of the principles recommendations in the 3D report and thinking of it through the lens of the African context. I really think if one were to look at the world, I think the rapid urbanization, population growth in Africa and the importance of social economic determinants really, as far as I'm concerned, make what's happening in the continent more interesting than what's happening in any other continent. So to hear all of you with those thoughts, I learned immensely from listening to all of you. So I want to say thank you. Thank you for the conversation. Thank you to the participants. And thank you to everybody for all you are doing for the health of populations. Everybody, have a good afternoon. Good